Okay, for our next talk, we're going to go to Zoom if I'm understanding correctly. We have Dr. Andrew Krystal, who's the Ray and Dagmar Dolby Distinguished Professor and Vice Chair of Research in the Department of Psychiatry at UCSF. Take it away.
Well, I really appreciate being invited to participate in this wonderful workshop. I would really love to be there in person, but unfortunately I got COVID and that prevented me from being able to travel. So I sent my brother to serve as an avatar. The topic of mood disorders and sleep is a really broad one. I can't possibly do justice to it, even parts of it in 10 minutes. I have to very much focus, and I'm going to focus on the relationship of insomnia and depression. These are my disclosures. So I'm going to just give a little background about the relationship of insomnia and depression, and then talk a bit about the fact that we have correlational links between the two, and ask, are these causative or just correlations? And I'm going to make the case that there's some degree of causation present, which presents an opportunity for intervention. So it's built right into the definition of major depression with the DSM, that insomnia or hypersomnia is highly linked. There's it's a 5 of 9 diagnosis, but one of those 5 symptoms that you could have and meet the criteria is either insomnia or hypersomnia. And accordingly, 70% of people roughly with depression have insomnia, but 20% report being sleepy during the day. And there's a long history of looking at, are these separate phenotypes? Do they matter? And so far, there's not a compelling rationale for distinguishing them as important phenotypes. I'm going to just focus on the insomnia side and first ask, is the insomnia best thought of as a symptom or something of independent importance, like that might be worth identifying and specifically treating? The traditional view has been that it's a symptom. For many years, it was widely believed and stated in important publications that you don't need to treat insomnia because it's a symptom of depression like low energy, and it should get better when the depression gets better with whatever treatment you deliver for the depression. But increasingly, there's been evidence that having insomnia has impacts on the course of depression in important ways, suggesting bidirectionality. This led to changing from having diagnoses like insomnia due to a medical disorder or a psychiatric disorder to a global diagnosis of insomnia disorder, which was meant to really recognize the co-occurrence of these. And a number of the key observations is that if you have insomnia at some time point and you don't currently have depression, you're at increased risk for depression emerging over the near future. If you have insomnia while you're depressed, it decreases the antidepressant response. Insomnia is an independent risk factor for suicidality, and in some studies, the most frequent residual symptom after antidepressant therapy that's otherwise successful. And having residual insomnia increases the risk of relapse. So this is just a slide that's old that shows the number of studies that show that having insomnia at one time point predicts the emergence of depression in the future. It's an important risk factor. And I stopped collecting studies in roughly 2000 here, and there's been as many since that have shown the same thing. Is this a correlation or is it causative? There's also more than 40 studies. This is also an old slide, and it's at least 5 years old. I bet there's more than 60 studies that show that insomnia predicts or is correlated with suicidality. This is at the same time. And this is true for ideation, intent, and attempts, and actual completed suicides. And it has been shown across multiple populations and age groups, and is present when you control for depression and other kinds of confounding factors. The current state of the art for assessing suicidality is to sit with somebody and say, do you have thoughts about hurting yourself or ending your life, or do you want to die? Do you intend to hurt yourself? Do you have a plan? These kinds of questions. It turns out that having insomnia is a better predictor of whether people attempt suicide than those questions. So it could be an important opportunity for identification of people at risk. But correlative or causative? So now I'm going to show you some of the data pointing to causation. Remarkably, and this may have something to do with NIH funding priorities, 3 studies emerge, and so NIH leadership should get some credit for this. About 3 studies have emerged around the same time in the last 2 years that where CBTI, cognitive behavioral therapy for insomnia, was delivered to people who have insomnia but not current depression, and followed them over time to see about the emergence of subsequent depression. And all 3 of them show that treatment of the insomnia decreases subsequent depression. Our group did one of these where we gave people who were pregnant and had insomnia during pregnancy cognitive behavioral therapy, and then we looked at postpartum depression. And in those who received usual care, 18% developed postpartum depression in the first 3 months post-delivery, but none of the CBTI recipients did. Now, of course, I don't believe that this is going to prevent all postpartum depression, and we are fortunate we're currently doing a study to try and replicate this. But there's probably some mitigation of risk, and that's the hope. A group at Henry Ford Hospital in Detroit was doing a study at the same time where they randomized people to a sleep education control, or also the other one was a digital CBT, and this is also a digital CBT study. And they showed that the severity of depression was decreased 1 year later. And they found, interestingly, that it was mediated by increasing resilience, that is, the capacity to handle adverse events and recover from stress. And they operationalized it in that way. A third study was done out of UCLA at the same time by Michael Irwin's group, and they randomized people to an in-person CBTI or a sleep education therapy condition. And they found that and followed people for 2 years, and they found that the emergence of depression was double the rate in the people who had the control education therapy versus the CBTI. So this is a set of 3 studies that done independently in 3 different populations, pregnancy and postpartum, older adults, younger adults, digital CBTI and in-person CBTI, all showing the same thing, which is suggesting some degree of causality and certainly an opportunity for intervention. Do we need to be identifying insomnia and making sure that we treat it effectively? One study was done related to the suicidality question, which I was fortunate to be part of. And we randomized people who had depression and suicidal ideation to fluoxetine plus zolpidem extended release or placebo. And we did find that on the Columbia Suicide Severity Rating Scale, the suicidal ideation decreased to a greater degree in the people who received the insomnia therapy than the healthy controls. And it's important to really answer the question of, does this extend to attempts? And of course, that's an extremely hard study to do. Hopefully, we'll get that information at some point. I can tell you that I added significantly to my grayness and hair loss out of doing this study over 5 years. It's very stressful to do suicidality research, but we really need to drill down on this further. So this suggests some degree of causality and another opportunity for intervention. Time is short, so I'm going to have to wrap up. But we have growing evidence of correlations that exist between insomnia and depression. And while it was unclear for a long time if these are correlative or causative, the recent evidence is suggesting some degree of causality there, which is an advance for us, I think. But we only know a few situations like this. The story about whether treating insomnia when you're currently depressed versus with an independent insomnia targeted therapy versus not addressing it directly is not well resolved. And also residual insomnia, preventing relapse is a correlation, but not been tested, and that kind of research is needed. We also need to try to understand mechanisms. We have some preliminary evidence from intracranial brain stimulation work with severe depressed patients that when you stimulate most of the areas that immediately lead to mood improvement, you get immediate alterations in sleep-wake function, either wake promoting or sleep enhancing. And so it suggests there's probably overlapping circuitry, and work that I've been fortunate to do with Inghui and Louis, who are in the room today, it suggests that genes that regulate sleep need also modulate resilience, which we heard earlier is a mediator of CBTI's mitigation of depression emergence effect. So that perhaps gives us a toehold to be able to better understand some mechanisms by which treating insomnia might improve depression outcomes. Lots more work to do. I'll stop there and thank my collaborators and appreciate being part of this.
Thank you, Dr. Krystal, for that terrific talk, and we hope you feel better from COVID as well.